Hello, welcome everyone to session 2 of the Health Center Preparedness and Response Forum focused on natural disasters. We're so glad that you're here to join us. We're going to go ahead and give people 1 minute to come into the link, so we'll get started here shortly. Good afternoon, welcome. And yes, as you're coming in, feel free to add to the chat. Let us know where you're joining us from. We are going to jump right in here in a second as people start to join today's webinar. Feel free to chime in, like I said in the chat, let us know where you're joining us from. And we're happy that you're here. Awesome, we've got a lot of people from different places. Thank you so much for joining us. We're going to go ahead and jump right in. Next slide. Many people are already familiar with Zoom, but in today's webinar, we just want to remind you of a couple of housekeeping items. So all of your cameras and audio are turned off, but we do encourage participation in the Q&A box and remind you of any shortcuts that you might need help with, or you can turn on the closed captions for any reason. But feel free to message Ivy in the chat if you need technical assistance to access today's information. The slides will be shared in the chat for those that prefer to follow along, and we will be releasing the transcript of the recording of this session within the week. We also do encourage you to provide us feedback, so please make sure to fill out today's evaluation after the webinar. Next slide. This forum is a collaboration between 11 different National Training and Technical Assistance Partners, or NTAPs. NTAPs provide free training and technical assistance to support health centers in a manner that increases patient safety and health outcomes so that you effectively serve your priority populations. To learn more about the NTAPs and the individual priority populations that we offer support to, please visit the link in the chat. So for today's session, we will be your moderators. My name is Gladys Carrillo, and I am the director of the National Center for Farmworker Health. And I am joined by my colleague.
Hi all, I'm Carrie Skillingstead. I use she, her pronouns, and I'm the Associate Director of Healthcare Transformation at the Association of Asian Pacific Community Health Organizations, or AAPCHO. And just to give a visual description, I'm a mixed race woman in my mid-30s with brown hair, and I'm wearing wire-framed glasses and have on a black shirt. And just for my own access needs today, I'm going to be reading from a script. Thanks, Gladys.
Thank you, Kara. She'll be chiming in here in a little bit. Next slide. So this is today's agenda. We just want to give you an overview of the session. We'll be covering some context on the topic, including how the topic of natural disasters impacts certain health center populations, as well as sharing some specific case studies from our NTAP priority populations. After that, we will have a little bit of information from our speaker today, Jamie Barney, and we'll be formally introducing her shortly in today's session. And then we will be sharing some additional resources on natural disaster preparedness and response. And if time permits, we will have some audience engagement activities, but we'll see how today's presentation goes. Next slide. So to start us off, we want to give an overview of what we mean by natural disasters. So as you can see by this information, today's presentation will focus on different sudden or unexpected events that can result in serious damage or death, and they can come in many forms. The list here is not extensive, so you can add some other natural disasters, whether they're man-made or not. But for today's presentation, we'll be talking about earthquakes, tornadoes, hurricanes, tsunamis, wildfires, and extreme heat will actually be covered in our next session, so we won't necessarily go into depth into today's presentation, but we're covering other events like landslides, volcanoes, floods, or winter storms. So just in general, disasters that impact our patient populations as well as health center operations. Next slide. So as we mentioned, on a national level, natural disasters do affect everyone, right? Including our priority populations. But a few things that we wanted to touch on is how now actually natural disasters have increased in frequency and severity. This information on this slide just gives you an overview of how natural disasters have evolved and what you can kind of expect in today's time, because natural disasters have more unpredictable and deadly weather patterns. They're also less warning or not as much time in order to prepare for these types of events, but they have a significant impact, especially on marginalized communities within the health centers that we provide service to. So as a result, it does give health centers less time to prepare and respond. So we bring this information so that you can have the opportunity to plan ahead, if possible, as much as you can, to be able to better respond to these events and also continue to serve the priority populations that are significantly affected by these events. Next slide. So a little bit about the disproportionate impact on these populations, especially because we as NTAPs, we serve priority populations, some of which we're going to be talking about in the slides to come. But we wanted to share how we've seen the impact that these populations have had in general. So this slide covers some of that information, because in experiencing a natural disaster, there's an increase in how the populations are displaced. And we've specifically seen this in communities of color. There has been a widespread global displacement in these communities, especially as climate chaos increases and the number of refugees continue to come to the United States from different places in different countries. So there's been an increase in that, but as a result, they are more widely displaced. Some populations also live in some substandard housing. So obviously natural disasters significantly impact them, but then these populations may have diverse language needs. And so being able to provide information in their native language or being able to offer emergency assistance in a timely fashion in their native language can be a challenge. So it's very important that as we begin to talk about how these issues impact populations, that you keep in mind their particular needs, and language is one of those areas. Another point that we wanted to really note is that natural disasters can reveal gaps and effects on systemic racism and structural poverty in health center populations. And I think we somewhat saw this, obviously, when COVID-19 affected the different patient populations that we serve. I think now in 2023, a few years later, we're still seeing the impact that COVID had on these communities. And so it definitely shows the different needs that the patients have and that health centers need to keep in mind and obviously include into their emergency preparedness planning when these types of events happen. In the next slides, we're going to go over a few of the case studies and particularly talk about the priority populations that we discussed. Now, please note that this is not an exhaustive list, and there are a myriad of ways that multiply marginalized patients that experience the impact of natural disasters. And I think, yes, next slide, Matt. Okay, here we go. We're going to first start with talking about agricultural workers. So the NTAP that I work with, National Center for Farmworker Health, we particularly serve this community, and we've seen the impact that natural disasters has on this population, because a lot of agricultural workers are work out in the elements. They are in the environment, and so that affects them directly in terms of the work that they do and also their health outcomes. So a few things that we've seen from different natural disaster events in terms of how it impacts this community is that because agricultural workers work outside or can't be exposed to the elements, if a natural disaster occurs, there's the impact that they might be losing wages or even not be able to work at all, depending on the extent of that event. So if there's a fire, if there's a flood, and this impacts the entire community, including the workplace that the agricultural worker is in, they obviously wouldn't be able to work, or they might wait to work until that disaster is cleared up, and they are able to return to work once that assistance is provided. So agricultural workers also, if there's some sort of natural disaster, this can change their migratory patterns. So if something happens in a specific region or area, they might need to travel to another area or another place because there's a change to crops or different farming. So again, because workers may follow the crops, if there's something that happens, they would need to go to a different location. And because I mentioned it earlier as well, that they are out in the elements and in working outside, this might increase their vulnerability to climate-related illnesses, or they might be exposed to more hazardous working conditions. And so this does increase their safety risks because it leaves this population more vulnerable just due to the nature of the work that they do. A lot of farm workers also do live in substandard or rural housing. So again, if there is a natural disaster, it can impact their access to assistance or healthcare, depending on their location. So this puts them at a different level of risk considering their housing. So this is a way that farm workers are impacted overall just by natural disasters that may occur in specific areas. Next slide. Another a community that we wanted to touch on is Asian Americans. So we wanted to specifically note a couple of examples. So despite being the fastest growing racial group and including over 50 ethnic identities with over 100 languages spoken, Asian American, Native Hawaiian, and Pacific Islanders still experience aggregation into a singular monologue. So this aggregation erases the unique and diverse needs and experiences of smaller racial and ethnic subgroups and prevents the ability to effectively identify and address existing health disparities. So with that, one example of a disproportionate impact of natural disasters on this population was the flooding in New York City caused by Hurricane Ida and the impact that it had on immigrants that lived in basements. Unfortunately, the majority of this, the way that this community was affected was that the majority of deaths were Asian Americans because of the flooding that happened in this city. So when examining existing health disparities among Asian Americans, it's important to consider the intersectionality and framework that really comes into play when looking at the communities and including, like I mentioned earlier, the different identities and languages spoken. So going back to being able to provide information in that native language is very important to really know your patient populations and be familiar with the needs that they have to convey that information in a timely fashion. So when also talking about other intersectionalities, we may want to consider factors like age, gender, sexual orientation, and others. just because there is a big complexity with that. One other note is that many Asian Americans bear a complex historical legacy that has significantly shaped relationships with healthcare systems. So we want to recognize the historical trauma of these populations due to colonization, exploitation, and displacement. And then I think I'm going to hand it off to Kara.
Thanks, Gladys. And Matt, you can go to the next slide. I really appreciate all that level setting and for sort of introducing this topic and sharing. I'm going to be sharing a bit more about some of the other health center populations, and just always want to name that this is an overview and it's not meant to be inclusive of all the disproportionate impacts on these populations or representative of each individual member of these populations. So if you are interested in learning more about any of the health center populations that we are going to share, please follow up with us and we'll be happy to direct you to some more directed resources. So with that, I'm going to share a bit about the impacts specifically on Native Hawaiian and Pacific Islander or NHPI populations. And because of their population size relative to Asian Americans, Native Hawaiians and Pacific Islanders experience erasure when data about the Asian American Pacific Islander monolith is aggregated. And this erasure, combined with the remote geographic location of the Pacifica region and the migratory patterns of many Pacifica patients, Native Hawaiians and Pacific Islanders often experience the first and worst impacts of natural disasters. For example, Native Hawaiians and other Pacific Islanders are experiencing some of the most devastating impacts of flooding caused by rising sea levels, including coastal erosion, flooding, heightened exposure to marine hazards, saltwater intrusion to surface and groundwater systems. They're also facing threats from increased storm surges, such as extreme tides and waves that cause coastal erosion, freshwater pollution, and other ecosystem devastation. And conversely, like more specifically to the Marshall Islands, ongoing nuclear testing in the Marshall Islands by the United States military has caused lasting and ongoing impacts of radioactive contamination. And the associated health and environmental impacts of radiation poisoning have displaced many Marshallese communities from their homes in the Pacifica region to the continental US, which includes a large resettlement area in Northwest Arkansas, which frequently experiences tornadoes. And in the previous years, when there's been some escalation and increasing in severity and frequency of tornadoes, many Marshallese resettled populations are experiencing some of the most devastating impacts of those tornadoes. So impacts to Native Hawaiian and Pacific Islanders doesn't just happen in the Pacifica region. And then lastly, there is a widespread misconception that people leave the Pacifica region or the islands because of rising sea levels alone, when actually there are a myriad of other reasons why people may migrate or immigrate, including the deep impacts of colonization, such as dispossession of land, rights, and cultural identity that have far-reaching implications for addressing the unique health needs of this population. So if you'd like to learn more about that, I encourage you to do research about Native Hawaiian and Pacific Islander experiences, and AAPCHO is happy to provide resources for that if you're interested. Next slide, please. So I'd like to share a bit about the impact on older adults, and this slide was shared with one of our national training and technical assistance partners, the National Center for Equitable Care for Elders. So according to the National Institutes of Health, older adults are more likely than any other age group to be a casualty of a weather emergency. Older adults are also more likely to be reliant on electricity-dependent equipment, and the inability of power to access can result in a medical crisis. Lastly, older adults are often isolated physically and socially, and those experiencing social isolation are less likely to receive emergency information or have an effective preparedness plan. For more information about this, the National Center for Equitable Care for Elders actually created a resource entitled Building Connections to Improve Weather Emergency Preparedness for Socially Isolated Older Adults. And we will share that in the chat. It is an excellent tool for health centers to support preparedness and response for their elder patients. And as a case study for one of the impacts of this, about half of the deaths during or in the aftermath of Hurricane Katrina in 2005 and Hurricane Sandy in 2012 were individuals who were over the age of 65. Yeah, pretty devastating. Next slide, please. And another disproportionately impacted health center population are unhoused populations or people experiencing houselessness or homelessness. And due to the rising global climates, the frequency and severity of hurricanes have steadily increased over time, as Gladys already mentioned. And we wanted to focus on specifically Hurricane Irma and its devastating impacts on our unhoused neighbors. Hurricane Irma was the strongest Atlantic hurricane ever recorded, and then was followed 2 weeks later by an even further record-breaking hurricane, Hurricane Maria, which was the costliest hurricane in the Caribbean on record. And these hurricanes caused widespread and catastrophic damage, and those who are often the first harmed by these disasters are unhoused populations who are living outside. And it's important to note that these tragedies are raceless and classless, though the same is not true of recovery from these tragedies. And it's often the most multiply marginalized unhoused communities, such as people of color or the LGBTQIA plus community, who are most disproportionately impacted and who receive the fewest resources for recovery when they're experiencing houselessness. Forced evacuations additionally can also lead to increases in mental health struggles caused by the chaos, loss, and lack of autonomy. So it's important as we're creating disaster planning to include unhoused populations and include contingencies for providing rapid and safe emergency shelter, access to food and supportive services, and in particular, mental health supports. And lastly, disaster response among unhoused populations should always incorporate a trauma-informed lens, which our speaker will actually talk a bit more about later. And if you'd like to read more about some specific disaster planning, the National Healthcare for the Homeless Council created a report called Disaster Planning for People Experiencing Homelessness, and that's been shared in the chat for anyone who'd like to read more. Next slide, please. Okay, and for our last health center population that we'd like to share about today, we wanted to talk a little bit about the impacts of residents of public and assisted housing. So many public housing units lack features necessary to adapt to the climate chaos that's occurring as a result of climate change. So include air conditioning, air filtration, insulation, and flood control measures for extreme heat, for air pollution, for extreme cold, and then other flooding caused by hurricanes, cyclones, and other disasters. And in public and assisted housing, many residents are elders or may have disabilities or other access and mobility needs, which exacerbate issues caused by living in substandard housing during emergencies. In the coastal states alone, there's over 25,000 housing units that are at risk of flooding due to sea level rise. And in response to this, the United States Department of Housing and Urban Development, or HUD, is currently engaged in efforts to reduce risk to public housing residents through preparedness, communication, and prevention. Preventative measures that they're seeking include but aren't limited to land use regulations and restrictions, energy efficient construction, green and resilient design, and transit-oriented development. And these programs will be supported through housing programs and block grants. I don't have a ton of additional reporting resources at this time, but if you're interested in learning more about this population, please reach out to us and we can follow up with some additional resources. Next slide. So that was a lot of information and we kind of were all over the place, but just wanted to bring us back to some of the key considerations as health centers that we can incorporate as we're moving towards preparedness and response for natural disasters. So health center preparedness sets up communities to really brace for recovery. So some key considerations we want to keep in mind as we're planning and organizing are health centers are striving to incorporate reliable support and strategies into their workflows. So it's critical that they embed resources and services that are culturally responsive. And for this to be accomplished, health centers must know the needs and challenges of their patient populations, including language, levels of education, levels of literacy, cultural practices and customs, disability justice, and other things. And resources must include in-language educational materials in print, visual, and audio formats for folks who who maybe speak English as a second language or who have limited English proficiency. And then partnerships with culturally specific agencies that understand the nuances, linguistic barriers, social stigmas, and other impacts that can impacts to access to resources are just critical for fostering that trust and rapport between health centers and their patient populations. And then lastly, collaboration with trusted leaders and culturally specific programs and organizations can significantly increase the effectiveness of outreach programming and translation efforts, and just overall improving community readiness to respond during natural disasters. So I don't want to get too much into the practical aspect of things because that is why we have this wonderful speaker today. So if you want to move on to the next slide. We have a wonderful person joining us today named Jamie Barney from the Open Healthcare Clinic in Louisiana. She is the Vice President of Behavioral Health Services. And we've talked a lot about the multiple impacts on health center populations, but we really want Jamie to share a bit more about some of the strategies and practical implementation for response and recovery. So I know, Jamie, you're going to discuss how you have historically prepared for and responded to flooding, and we are so excited for your presentation today. So I will turn it over to you.
Thank you very much. Thank you for having me, and thank you for trusting me to share some information on Open Healthcare Clinic and the work that we have done historically and those things that have demonstrated to be important while preparing for and responding to severe weather events. Next slide. So you can go on to the next slide. Open Healthcare Clinic, our legal name is HIV/AIDS Alliance for Region 2. We were established in 1995. We started off providing housing services. We still have several HUD-funded housing services with HOPWA and Continuum of Care housing. And we became a full-service medical clinic in 2007. Obtained a federally qualified health center status in 2015, and we rebranded as Open Healthcare Clinic. As you can see from the map, we are in the South, a little north of New Orleans, Louisiana, where the little red star is on the map. Next slide. So we provide an array of services. We apply a wraparound model to all of our patients with primary care for pediatrics and adults. We do women's health, endocrinology, podiatry, sexual health. We have a pharmacy, and we provide oral health, behavioral health, and social services. Next slide. So we see an abundance of vulnerable subpopulations in a multitude of different categories. These are those persons who we found especially vulnerable to severe weather events. And so that is our patients with chronic conditions, including persons living with HIV, persons experiencing homelessness, persons with mental health disorders, those with no income or very low income, and those patients who are not able to speak proficient English. So almost 1,000 of our patients are persons living with HIV. And then also in Baton Rouge area, we had in June, July, and August of 2023 of this year, there were 25 heat-related deaths in Louisiana, according to the Louisiana Department of Health. And we have an integrated care model. So we try to apply behavioral health into our primary care services and provide medication management and counseling. So we have a significant number of patients with mental health diagnoses, and 57% of our patients are Medicaid patients, and about 24% of our patients speak Spanish as their primary language. Next slide. So I am going to go into our emergency operations plan. These are the main components of it, those that we, that are very vital to make sure they're addressed. So our plan starts off with the demographics of all of our locations. So that includes the address, the layout, and all of the services with maps and floor plans at each of the locations. And then it goes into command and control. So that's our organizational chart. That includes the delegation of authority, which identifies who is authorized to activate our emergency operation plan, make decisions, and act on behalf of the facility if leadership is unavailable during emergencies. And then it also goes into orders of succession and where our command center will be located. A lot of times with hurricanes, even after the storm is over, the cell phones or landlines do not work at all. So we identify where those persons in leadership or in staff should go if we do have a severe weather event. And then it goes into policies and procedures, specifically detailing what should happen with facility lockdowns, shelter in place, evacuation, suspending services, and documentation of those events and decision making. It goes into internal communication, which is the communication that needs to happen with our staff, and then external communication, when we should be contacting 911, the property owner at each of the locations, parish, state, and local emergency management persons, other facilities that can provide required services, like other FQHCs in the area, and nearby hospitals for emergency services. It goes into communication with our clients and our visitors that are on site or who are scheduled to come on site. The training required with our staff and testing the different systems with our different drills. And then also contact information for vendors of medical equipment, supplies, our electronic health record, pharmacy, lab service, and dental equipment and supplies. So it literally lists all of the phone numbers, email addresses, and direct contact. And then it goes into the codes with more detail. So at Open Health, we have codes for fire, bomb, active shooter, infant or child abduction, medical emergencies, severe weather, and violence. And so I know that is a lot, but in a nutshell, our emergency operations plan includes all of those things. It's a very lengthy document. Next slide. So we're going to be talking about our code gray, which is severe weather. And I know that a lot of health centers specifically use the same color, so that makes it easier, for our staff to remember the color code. No need to invent the wheel. So for our code gray, the activation occurs when there's a situation that's related to imminent severe weather conditions and had a potential to cause physical harm or destruction of property. So at that point, our CEO is the first in our emergency operations plan that would activate the emergency management team, and we will start observing the weather patterns. We have most of our conference rooms have screens for meetings and such, but we will put them on like the weather channels, and you'll see people kind of dipping in and out. Our COO may be set up in there for the day if we know a hurricane is coming in our direction, and that'll kind of be our command center before we go, before we leave if we are suspending services. So for a watch, if we have National or State Weather Service issue a severe tornado, flood, or hurricane watch, all staff are notified electronically or via email or text. If we go into a warning, that is if it's issued, staff are notified electronically. So I always mix up the watch and the warning. That's why I'm trying to watch my notes. So if there is a tornado warning, so it's picked up on radar or seen, then we announce the code gray. We always make sure we use plain language with our code. So it'll be code gray, tornado warning, which building location is affected, seek cover now. And so our staff are going to account for all of our patients and assist patients and visitors away from windows. We're going to secure windows and doors, gather our flashlights in the area, And then if necessary, we'll instruct our staff and visitors into a position to protect their head and eyes best they can. If we have flood warning or ice or snow warning, our CEO is gonna make the necessary determination of the necessary action based on information on where services are located. And for hurricane warnings, that's if we're expecting a hurricane within 24 hours to impact one of our locations. We're watching for the governor's declaration of a state of an emergency. That's when our emergency management team is activated, staff is put on alert. We coordinate plans for continuity of operations. And when warranted, we implement the procedures for our office closure. And then our CEO will determine when our organization's response is no longer needed, when we can go back into regular service provision. And hopefully that, happens soon, but it varies. Next slide. So this is going to bring us into a case study. This happens around in August of 2016. So this is one of our families that was impacted by a major flood here. What was going on in our community at the time, and then how our organization responded to it all. So we'll kind of go back and forth. So we had a 52-year-old woman who was the head of household for a family of 5. She resided with her daughter, 2 minor grandchildren, and her minor son. And the household's income consisted of her Social Security disability and her daughter's employment. She was diagnosed with HIV, bipolar disorder, and schizophrenia. She had been in the home for 6 years at that point, and she was receiving medical care in Ryan White Case Management at Open Healthcare Clinic. She was receiving mental health services from a different community partner, and she resided in our HOPWA-funded project-based housing, which was a 3-bedroom home. She had a stroke and was hospitalized for 3 weeks. And during this hospitalization, there was 4 days of rain resulting in a flood. Initially, her home was inaccessible, but when she was able to regain access, most of her items were ruined with 2.5 feet of water in the home. Next slide. And so that ended in what we call the Great Flood of 2016. People call it the No Name Storm, and it was also called a 1 in 1,000 year flood. It was a rainy weekend in August. It lasted 4 days, but it unexpectedly left behind more than 3 times the amount of rain dropped by Hurricane Katrina. And for the first time in Louisiana's history, Baton Rouge flooding forced the governor and his family out of the governor's mansion when chest-high water filled the basement. Unfortunately, there were 13 persons who lost their lives due to flooding, and an estimated 41,000 housing units were damaged in East Baton Rouge Parish. Next slide. So immediately upon returning to work from the floods at Open Healthcare Clinic, our Ryan White case managers stopped what they normally would do on a regular day and started locating clients and identifying immediate needs. We had one behavioral health counselor at the time, and she had just started a month prior. And I actually started right after the floods on August 16th. That was my first day at this organization. But she was focused on supporting established and new patients and staff while she was still trying to orient to the organization. With our housing program, our housing case managers and managers went about identifying clients that were displaced and assessing damage to our properties that were with HOPWA's project-based program. And then in our medical clinic, our staff went about locating patients, identifying appropriate pharmacy for those patients who were displaced, and medical visits as needed. So our providers came in and they were willing to see patients and send prescriptions wherever they needed to go. Meanwhile, our staff was doing a lot of work, but a significant number of them were displaced or hosting family and friends who were displaced and had damage to their own home. Next slide, please. So that is one of the articles that shows one family that had 13 homes destroyed because the family lived in the same neighborhood, and how that family pretty much were trying to pool all of their resources just to survive. And there was a lot of that happening at the time. But as far as the patient we're discussing, upon release from the hospital, she and her family moved in with her mother. They stayed with her mother for approximately 2 months while we were working to identify housing for her. Next slide. So I was able to go back in my emails and find our operation updates from this time in September of 2016. So it shows what our caseload was, and that within 1 week of the floods, we were able to contact most of our clients. 50 of our clients were displaced immediately following the floods, and 15 remained displaced in Ryan White case management. Any of our clients who were without medications, we were able to get them to them within 48 hours. And those of us working with persons living with HIV, we know how important it is for them to take their medication consistently and not miss doses. While we were able to provide for most of their immediate needs, there were additional needs identified, including formula, sanitary supplies for women, and rehousing. Within our housing program, we had 8 housing clients that were displaced. There were several that were still unaccounted for, and we were communicating with HUD and OCD, which in Baton Rouge manages our HOPWA grant with the city, to fund the full extent of, to see if we would get assistance with funding repairs and trying to reallocate some funds to be able to house patients that were in need. So our focus shifted to assisting patients in accessing needed resources. We worked a lot with FEMA. We had a difficult time securing contractors because the cost of everything rises dramatically after a storm, and trying to determine the length of time housing was available, making sure we stopped monthly payments for clients that were not housed, and then racing to secure safe housing again as the prices on rent increase. Next slide. So our patient continued to access mental health services with a community partner, even while she was displaced and living with her mother. She was still receiving Ryan White and housing case management, and the medical provider was still maintaining regular follow-up while she was displaced, and ensuring that other members of the household had access to medical and mental health services. That is for Health Centers Week. 1 week we did like a hero thing. It was really cute, but that's the staff, because again, they continued to make sure our patients had everything they need while they themselves were struggling with being displaced and hosting other families. Next slide. So this is shifting a little bit to the mental health issues that arise as a result of going through these things. When you're in the midst of a severe weather event, you don't necessarily have time to focus on mental health. You're just trying to make sure you're meeting basic needs. But there was a survey done by Louisiana Spirit. They used federal emergency money to help victims recover following declared disasters. And their survey showed that a quarter of survivors surveyed told the agency staff they were having trouble making decisions. 1 in 5 said they felt irritable and angry. Police figures showed that domestic violence increased, and so also had drinking. And that information is in that very last paragraph there. It also noted one person who survived the flooding was talking about how fast the water came in, not having time to think. All you can do is get out, get the kids out, get out. And then after the flood, she couldn't concentrate. She couldn't do anything. Her mind was just trying to comprehend what's going on. And so when we're looking at, of course, common symptoms that persons experience with depression, anxiety, and post-traumatic stress disorder, we'll see an increase in those. With depression, it's feeling of sadness or loss of interest, and that can lead into a range of behavior and physical symptoms. With anxiety, that'll be feeling nervous, restless, or tense, or having sense of impending danger or panic or doom. And then with post-traumatic stress disorder, that may include nightmares, unwanted memory of trauma, avoiding situations that bring back memories of trauma, heightened reactions, anxiety, or depressed mood. We had several persons who came here to Baton Rouge from New Orleans after Hurricane Katrina. They finally get settled and then lose everything again in this flood. And so still now we have some coworkers who, when it looks like it's going to rain pretty bad, you can see anxiety. They already start planning. They want to move stuff out. Let's get the family out. Which a big part of it is safety, but also a big part of it is symptoms of post-traumatic stress disorder. Next slide. So stress is very impactful on the body. Again, as a health center, we're all about whole care for all of our patients. And when we're looking at how stress can impact your health, it's going to cause problems with concentration and sleeping. You'll have an increased heart rate, risk of a heart attack. With your immune system, it'll be more difficult to fight and recover from illness. Men see lower sperm production and women have increased period pain. There's also aches and muscles in joints and aches and pains in joints and muscles and lower bone density. Next slide. So when we're responding to stress and we're trying to help persons dealing with anxiety, depression, and post-traumatic stress disorder, one thing that's very important to take note of is one size does not fit all. There's an abundance of resources, and what resource we refer a patient to or what combination of resources varies depending on the person. So there's self-help things, there's individual counseling, there's psychiatric services, support groups, and emergency and crisis information listed. So we always want to make sure our patients know what to do if their symptoms rise to the point where they feel like they're in emergency. And one safe bet is to make sure they know to dial 911 or 988, or go to the nearest emergency department. But we want to make sure we're careful about not stigmatizing any mental health treatment that may help someone else. So if you have tried counseling and it does not work, we want to make sure we don't tell anyone don't try that because it may be very beneficial for them. And with self-help, journaling, finding time to do things you enjoy, exercising, and getting sunlight are always very beneficial. And then with post-traumatic stress disorder, there's an abundance of grounding techniques. One is the 5-4-3-2-1 method. So working backward from 5, you want to use your senses to list things around you. So you might want to start by listing 5 things you hear, 4 things you see, 3 things you can touch from where you're sitting, 2 things you can smell, and 1 thing you can taste. So people may use things like that if they feel they're going into a panic attack to kind of ground yourself and realize that you are safe. You're physically somewhere. You can touch the paper. You can touch the desk. Everything's okay. There's not actually a crisis happening right now, even though your body feels that way because it's starting to rain. Next slide. And so that's where also trauma-informed care models come in. So pretty much with a trauma and care form model, you are realizing that there's widespread impact of trauma and understand that there's different pathways to recovery. You want to recognize signs and symptoms of trauma in patients, families, and staff. And you want to integrate that knowledge into your policies, procedures, and practices and actively avoid re-traumatizing anyone. So as a supervisor in this organization, after we have a severe weather event, I recognize that my staff are maybe traumatized. I'm going to assume that they are, even if they don't communicate that to me. So if someone gets a little snippy with me, a little short in the email, we're going to give each other grace. We're going to give them space. We have 8 counselors providing mental health services. And so they may be dealing with their own trauma and also trying to help someone through trauma of the same type. And just going to them and checking in and saying, do you need to take 15-20 minutes to talk or just sit alone in a quiet space before you go into this meeting? Those type of things go a long way. Next slide. So with the patient that we've been discussing, she and her housing case manager were able to identify safe housing for the family. We were able to work with the city to reallocate our project-based funds to tenant-based because the projects weren't available anymore. And we moved that patient into a 3-bedroom apartment. HALQA funds were able to be used to renovate the home, and those renovations were completed a year later. And we were able to house another family in that home within a week of completing those renovations. Next slide. And so mainly our goal is prepare, response, recovery. That's kind of how HRSA sets theirs up. But I think communication is so important. So I just kind of prepare, communicate, respond, kind of twisted theirs a little bit. But again, we have our emergency management team. We want to make sure that we have technology available, know what we have, and use it to the best of our ability, like what locations have the generator, make sure our facilities team continues to get alerts if the power goes out, our temperatures are out of range for medications. We have to make sure we're responding and moving quickly. We have necessary tools to make decisions quickly. We have persons who are in communication and receiving updates from the Office of Public Health, the governor's office, weather channels. We're making sure we're communicating with our clients in a way that they understand, like the other speakers mentioned before. So we're posting and in a way they can receive it. So we're sending it through social media, through the portal. We're posting it on the door. We're making sure we have it in multiple languages. And we're having staff reach out directly through phone. We're communicating with staff, with our text system, with our emails, and making sure we're referring our employees for employee wellness. We actually enacted an employee assistance fund this year to help support our staff's financial well-being during crises, as well as their mental well-being. We minimize closures as much as we're safely able to do so. So we always have our skeleton crew and know who can get to which locations, even if there's flooding or downed wires, and know where our command center is. And then we are making sure we're aware of what resources are needed. So when we do have an opportunity of funds become available, we're able to quickly identify what we need, grab it, and fill whatever need patients have. And so I think that is it for me. That was my last slide. So I am open to any questions that
Yes,
anyone may have.
thank you so much, Jamie. That was a lot of great information, and I think you provided a solid example of the importance of really having that preparedness plan in place. We did receive several questions, but I think we might have time for a couple real quick. And so is it okay for those that we're not able to reach, that we can follow up with you and provide those questions afterwards?
Yes.
So one of the questions that came in that I think really guides a lot of the ones following has a lot to do with, how do you develop this emergency operations plan? You know, what guidelines, tools, or resources did you use to establish that? Because as you said earlier, that's the key, right? Your staff know where to go, who to contact, how to contact, what information is shared. So, and that stems from the plan. So can you share a little bit about that, about what you use to develop that at your center?
Yes. So we have a so I didn't develop the plan. I don't want to seem like I'm taking responsibility for it. So our chief operations officer, she's Dawn Beasley, and at the time, Jason Kramer, he's not with our organization anymore, but he did a lot of work on it, and he was with our quality team. But they pulled information from CMS and from HRSA. So there's guidance from CMS on emergency preparedness requirements for Medicare and Medicaid providers. And then HRSA has some emergency preparedness requirements, and then continuity of operations resources. And so there's a multitude of guides available from those entities. And so pretty much they pulled from them. And we work a lot with I don't know why the name of it is escaping, but the organization in Louisiana that works with primary care associations, and we do tabletop exercises, and so we'll amend our plan we have to review it annually, update it annually. And so it has grown to be, I think, very efficient from a use of a multitude of resources and looking at what we have locally and what works for us.
That's great. And I think that's what the key is. You tailor it to what works for you. You look at your environment, your patient populations. And so I think for our attendees today, that's key, right? Look at who your patient populations are, what are their needs, what are your current resources. And I think the other aspect is who are those community partners that you can collaborate with to bring into fruition this plan and be able to maximize the resources you have available. You gave a really good example of how you collaborate with your community partners. So I'll do one more question before we wrap up, and I'll pass the rest to you. We'll be in touch with you, Jamie, so you can address some of the others. But in terms of communications, you said that was key. We had a couple questions of how do you utilize communications when cell towers are down, and if you have any specific emergency mass communication system that you utilize for your patients. And is that just for patients or for also your staff?
For patients and staff. So with patients, so with hurricanes, you have a benefit of knowing when it's coming, so you have a little more time to prepare. Sometimes with the flooding, like the Great Flood, they kind of surprised us. So with phones being down, we do not have an answer, a great answer for that, because they're down. So we have walkie-talkies, but of course you got to be within a certain range to use those. We have some of those satellite phones, but when we tried to use them, apparently you had to stand on the car and hold your arm out, so they didn't work too great. So the main thing is knowing where everyone goes. So we know if we have a severe weather event right now, we have this specific location that has multiple generators, and that if you can get there, that is where you go. And that's where we'll base our operations out of. So we push out messages. We have the 3CX app. And so everyone with that app can make calls on a phone if the phones are working. We have a text messaging system, Text HR, that will push alerts out through that. We're on social media, so we'll post it to social media as well in case anyone gets Wi-Fi or is able to access the internet. And we use Athena as electronic medical record. And so we push messages out on a portal as well. So if we have issues with service and connection, we're going to put it out as many ways as possible, and then make sure we have signage posted on the location doors with a phone number you can call or where you can go where we're providing services, in case someone just goes to the building and can't use the phone.
Thank you so much, Jamie. So as you can see, everyone, it takes a lot of planning so that you can have all of these pieces into place to be able to act on them quickly and swiftly in these emergency situations. So that's all the time we have for questions, but we'll make sure to follow up with you, Jamie. Thank you so much for providing such great information today. And so for our attendees, we will definitely follow up with additional responses to the questions we weren't able to address during today's presentation. So as we wrap up, I did want to highlight real quickly the screen you'll see right now. We have our Emergency Health Center Preparedness Forum website where you can view the resources and as well as the recording and presentation links from today's session. The PowerPoint will include some additional resources that we didn't get to touch on today, but you're definitely welcome to download those resources from the PowerPoint slides. And with that, we'll go to the next slide to be able to provide the evaluation link to everyone, and also to thank you and welcome you to register for the next session happening in February 8th, 2024, which, as I mentioned at the beginning, will be focusing on extreme heat and wildfires. So today we kind of touched on those other natural disasters, but the one in February will focus really on these two extreme weather elements and wildfires that impact priority populations. So with that, we just want to thank you for joining us in today's presentation. Again, we appreciate you coming to today's webinar and wish you the happiest of holidays as we wrap up the year, and welcome, join us for 2024 in our next session. Thank you so much.